Thank you, Dr. Mittal. I hope you're able to hear me.
Yes.
Okay. Thank you, Dr. Mittal, for that kind introduction. And thanks to Dr. Mohit Gupta for inviting me to give this talk. Originally, I was allotted 15 minutes. Now you're asking me to cut down to 12 minutes. Let me try and do that. So the question is, what should we consider while developing guidelines? I think these are the following things that are required when we make guidelines. We need sound epidemiological data, particularly longitudinal data through cohort studies. We need robust data from clinical trials. And we need to address the context where we are framing the guidelines. We need to also look into culture sensitivity. For example, when we say salt reduction, how are we going to ask people who are attuned to high salt consumption, how do we kind of reduce? So we need to address that. We need to look at cost and cost effectiveness, and we need to look at equity, that is, the drugs or the treatment or the advice should be universally available. We recently conducted a review on why ethnicity, culture, and context matter in prevention and management of cardiovascular disease in LMIC. And we argue that ethnicity, culture, and context matter in determining the risk factors for disease as well as the comparative effectiveness of medications and other interventions, particularly diet and lifestyle interventions. And there's a lot of evidence. I wouldn't get into it because of paucity of time. I just wanted to posit something here. When we decide about hypertension, which drug, if you recall, till 2013, beta blockers was the cornerstone. In fact, it was the initial therapy according to the Western guidelines, and we also followed the same. But the Indian Society of Hypertension had the same kind of guidelines for that. So when you look at the Indian or the South Asian phenotype, we have low HDL cholesterol, we have high triglycerides, we have dysglycemia and metabolic syndrome, we have central adiposity, and we do limited exercise. Now, what does beta blocker do? It lowers HDL cholesterol, it raises triglycerides, raises blood sugar and insulin resistance, it raises body weight, and reduces exercise. All of the things that we do not want. But the fact is, as I said, till 2013, beta blockers were the first choice. And the other fact is there have been no specific hypertension trials, virtually no cardiovascular trials in South Asians independently. There have been in the last 10, 15 years patients from South Asia, but specific questions focused to what should be done in South Asians has not been there. So the question is, what do we do till we have our own data? I don't know what happened. Uh, have our own data. So I'm going to talk about the ISH guidelines, of which I was a member in developing those guidelines. So when we reviewed the literature for the ISH guidelines, worldwide there were several guidelines, and the most prominent ones amongst those, as all of you know, are the ACC AHA guidelines and the ESC ESH guidelines and the NICE guidelines. So the idea was to develop based on evidence criteria that can be used globally to be fit for application across all the settings, be it low resource or high resource settings. And so we had two criteria. One was what is really essential in terms of following the guidelines, and the second was optimal that would conform to the current standards of care. And it needed to be concise, simplified. The many of the guidelines are 100 pages, 150 pages, which no one reads, but we wanted a very concise, simplified, and easy to use guidelines by clinicians and all healthcare providers. The goals were to develop a balanced, practical, realistic, feasible, hands-on proposal for global use in line with the ISH mission, and use recent guidelines as background and define essential versus optimal criteria of diagnosis and treatment according to resources availability in the low middle income and high middle income settings. So there were 9 practical questions that were addressed. Because of paucity of time, I'm not going to talk about all, but I'm going to talk about 3 main things. One is, how do we define hypertension? Second is, when do we initiate treatment? And the third is, what are the drug choices that we have, which every clinician wants to ask. That there are others which you can actually read, but I'm just going to talk about these 3 things. So in terms of classification of hypertension based on office blood pressure measurement, the ISH guidelines define normal blood pressure as less than 130 and less than 130 systolic and less than 85 as diastolic. And high normal blood pressure was between 130 to 139 and or diastolic blood pressure of 85 to 89. Grade 1 hypertension was defined as blood pressure between 140 to 159 and or 90 to 99 diastolic, and grade 2 hypertension was greater than or equal to 160 by 100. So this essentially was the diagnosis. This is at variance somewhat with the ACC AHA guidelines, but almost close to the ESC guidelines. I'm not getting into the ambulatory blood pressure monitoring and home-based blood pressure monitoring, but here they are essentially saying that the daytime or awake average has to be greater than 135 or greater than 85 to be defined as hypertension, and the nighttime or sleep average should be greater than 120 and greater than 70. So that is, if you have the ambulatory blood pressure, you could do that. And there are guidelines as to how to measure the blood pressure, because that is an important variable in terms of classifying people into hypertension. Basically, the way the patient should sit, the patient should not be talking, cuff size to fit the arms, and validated apparatus, and so on. And in terms of when do you actually classify the patient to a hypertension, they should have had at least 2 to 3 office visits at 1 to 4 week intervals. And whenever possible, the diagnosis should not be made on a single visit. But if you have to make it, if the BP is definitely is more than 180 by 110, you can start the treatment immediately. But in certain circumstances, you could do it 2 or 3 times if the patient is not going to come back. If possible and available, the diagnosis of hypertension should be confirmed by an out-of-office measurement because of the white coat hypertension. Optimally, the initial evaluation should be measured in both the arms. If the difference is more than 10 millimeter, use the arm with the higher blood pressure. But more than 20 millimeters of mercury, it should trigger an investigation for secondary hypertension. Where there is postural hypertension, one should use standing blood pressure. And the SPRINT trial, which was carried out in the US, suggests an unattended blood pressure because it takes away the white coat hypertension component. So this is as regard the diagnosis is concerned. In terms of drug treatment for hypertension, this flow chart gives the drug treatment of hypertension, the thresholds and targets. Whatever the level of hypertension may be, most important is to provide lifestyle advice as an adjunct to drug therapy. If the patient has grade 2 hypertension, that is blood pressure greater than 160 by 100, immediate drug treatment is required in all patients. If the patient has grade 1 hypertension and patient has comorbidities like cardiovascular disease, chronic kidney disease, diabetes, or end organ damage, we need to look at adding drug treatment immediately. But there are situations where the drug availability is limited, in which case lifestyle intervention should be attempted for 3 to 6 months. But in presence of end organ damage, drug treatment should be started. So the treatment reduction should be at least to the tune of 20 by 10 millimeters of mercury, ideally to less than 140 by 90. In those who are less than 65 years, BP target should be less than 130 by 80 if tolerated, but it should always be greater than 120 by 70. If the person is more than 65 years of age, the BP target should be less than 140 by 90 if tolerated, but consider an individualized BP target in the context of people are frail, thin, and there are other issues which preclude treatment. Now, coming to the drugs, what should be the drug treatment? Optimally, we have a stepped approach. In step 1, you should try out a dual low dose combination. The earlier case of where we start with one drug, increase it to the maximal dosage, then add another drug is gone. We should start with half doses or 1/3 doses of 2 drug combination, preferably AS or R plus a calcium channel blocker. Then we can go to the step 2 would be going to the full dose combination, and step 3 would be to add a diuretic. In resistant hypertension, a triple combination plus spironolactone or any other drug should be tried. And ideally, these drugs should be given as single pill combination, but if single pill combinations are not available, we could give them independently. We could consider monotherapy in low risk grade 1 hypertension or in the very old, because you don't want to bring down the blood pressure very rapidly. In post-stroke patient, ACE inhibitor plus diuretic may be a better combination, or where patients have incipient heart failure or calcium channel blocker intolerance. We need to be cautious, obviously, with spironolactone and other potassium-sparing diuretics. But the caveat is, if these are not available, use whatever is available to reduce the blood pressure. What are the ideal drug characteristics for antihypertensives? Treatment should be evidence-based in relation to morbidity and mortality prevention. Use once a daily regimen which produces 24-hour blood pressure control. Treatment should be affordable and or cost-effective relative to other agents. Treatment should be well tolerated, and evidence of benefits of use of the medication in populations to which it is to be applied. We should show clear-cut evidence. The risk-benefit ratio should be favorable, and that should be the sole criteria, because we have so many drugs in terms of antihypertensives. cost, because these are drugs which have to be given lifelong, cost matters. So, in summary, in established hypertension uncontrolled by lifestyle measurement, treatment threshold should be more than 140 by 90, and the drug treatment target for less than 65 years should be less than 130 by 80, and for the more than 65 years should be less than 140 by 90. Uh, but we need to reduce, this is essential, we need to reduce in everybody by blood pressure of more than 20 by 10, depending on what your initial blood pressure levels were. And in terms of drug treatment, up titration to the target of low dose ACE inhibitor plus calcium channel blocker, then to full dose ACE inhibitor plus calcium channel blocker, then a diuretic should be added. And in the fourth step, if required, spironolactone can be added. Consider other initial combinations. For example, beta blockers would be useful in patients who already have have had a past myocardial infarction with hypertension. So those kind of situations, or heart failure, those kind of situations, we should use beta blockers, for example. Use single pill combinations where possible, and use thiazide-like diuretics preferentially, because most of the evidence comes from thiazide-like diuretics such as chlorthalidone and indapamide. Now, this is as far as the ISH guidelines are concerned. How do we develop our own guidelines to the Indian context? And I want to flag two issues here. One, we are embarking on a trial called TOPSPIN, which is treatment optimization for blood pressure with single pill combinations in India. That's because hypertension prevalence is close to 30 to 35% across the country, and most patients in India need more than two drugs to reach BP targets. Current guidelines on drug choices and sequencing in India are based on international guidelines, which may or may not be applicable to our patients. And there are no randomized trial data that are available comparing two drug combinations of antihypertensive therapies to help physicians make informed choices of BP lowering therapies. So this is the trial which we will embark, which will start sometime in May or June. It tries to compare the efficacy of three single pill combinations of two antihypertensive agents on 24-hour ambulatory systolic blood pressure among individuals with hypertension in India. It's going to be a multi-center, individual, randomized, single-blind, parallel group, three-armed superiority trial. We're going to recruit close to 2,000 patients in total, and more than 650 patients per arm. And the treatments that we are going to compare are a combination of amlodipine and perindopril, perindopril and indapamide, and amlodipine and indapamide. And the primary endpoint is ambulatory blood pressure, systolic blood pressure at 6 months, adjusted for the baseline ambulatory systolic blood pressure.
We are up with time, sir.
Okay, this is my last slide. So the other thing that we really require to do is we require longitudinal data, and we have embarked on a cohort study where we have had 3 blood pressure measurements so far. We're waiting for the fourth one for a 10-year follow-up, and that will give Framingham-like data in terms of understanding the risk for hypertension, what should be the comorbidities, and so on. So finally, we have traveled quite far. In 1931, John Hay said the greatest danger to a man with a high blood pressure lies in its discovery, because then some fool is certain to try and reduce it. And we are now talking about the SPIN trial where we want to go to the lowest level of 120 by 80. But the truth is that we don't have to go that far. What we need in India is now a contextual, evidence-based, cost-effective, and universal solution. And I hope that the 2 studies that I mentioned, and there may be others too, which others are embarking, will help us decide as to what we should do for ourselves. Thank you very much for this patient hearing.